Good evening. For today, all of my beloved colleagues and OSCE aspirants are here mostly today. My gentle introduction as before, and from the Institute welcoming you to today's session. Might be many of us busy in their OSCE preparation and practice today just to have a get together and discuss. Let us see now. We will talk a little just to give you again some revised impression, and if you have any query today, we will discuss each other within very short time. We will try to finish because this time is very important for you and you need to do more and more practice, no doubt. So somebody, can you open the mic also if you want to talk, as we will be in the very small group method today in the discussion. So you can keep your mic open also if you don't have any noise. So let me start my talk. This is the blueprint, I think visible to you, though little visual puzzling is there. The case selected from the systems, these are the major system, plus category of the acute chronic psychosocial prevention, lifestyle, including many other, that the breaking bad news separately, angry patient. These are called under the headline of the miscellaneous. We discussed many times before. So most of systems are selected, but very interesting thing is that you may not understand from which system the patient is selected. Even which case will be very acute and chronic, it also from the very beginning you may not understand, because the nature of the instruction is very simple, non-specified, but there might be some clue also. We discussed many often. Then this is your mark sheet, and what are the headlines in the mark sheet, you understand. We took a long discussion also before, just to refresh your memory. Major 4 types of scoring are there, though there should be some sub headlines also. Today we will discuss a little from there. And lastly, there is another point, is the overall assessment. It depends upon the examiner's overall assessment. They can give you also this 4 grading: excellent, competent, unsatisfactory, and poor. So you will get 4 score maximum in each skill. So your maximum score will be in general 20. So when you practice each other, you will try to give or assess the scoring for your friends, those who are practicing with. Try your best. So practice will not be single one, preferably with minimum 2, and the 3 is better. Otherwise, who will give you the marking? Who will assess you? And we'll discuss later also to summarize at the end. So just in a bigger screen, you see the consultation skill. We try to give you different color contrast to let you understand that what are the important keywords are there. This is again the 5 headlines, including the overall assessment. And so we'll start with the first skill, is the consultation skill. I think all of you know today about the consultation skill. And in the consultation skill, communication and consultation skill, the same thing. So based upon which principle you will be marked. These are the Royal College of UK, Royal College of General Practitioners UK, decided this. Near about 23 skills are there. So we actually a little modified for your better understanding here. Overall, the 23 principles should govern your consultation. 23 basic rules. Each and every rule you must know. I believe that most of you have gone through this, and even in our YouTube also, the links is open for everyone how to do it. So those are, if any newer colleagues are here, you can go through the detail. And this, the YouTube link, you can search there. Our YouTube name is the MRCP preparation by DOAMS. This is the latest naming of the YouTube. So this is YouTube there, a link always given in the group. So in the consultation, very important point just to let you know is the jargons. And in our previous practice course in the last month, and it was very happy to know that most of the candidates overcome their limitations of the jargons. I can remember. And jargons is actually a matter, almost you can cover yourself 99%. Might be there is some slip of tongue. So those who are alert, you may be competent about jargons in your skill, in your quality, near about 100%. So again, regarding jargons also, we discussed a lot in our YouTube. You can go there. So second skill is the history taking. Traditionally, it is told as a data gathering skill. In your examination mark sheet also named as data gathering. This is very important. The data, the detailed history will be very big one. But from the detailed history list, you have to be pertinent and related with the problem, clinical problem in the question. Pertinent in simple word, we can say focused history, not all the headlines of the history. So in our little observation, we like to share with you that there are some routine parts of the history which really pertinent. Sometimes we think that it may not be pertinent, but it will be really pertinent according to the age of the patient, according to the gender of the patient. And there are some excretory materials coming out from the body, and what relevant informations we must know. We will show you a little later in the chart. So it should be pertinent. Don't not needed that all the systemic inquiry also will be there. If you think that your patient presented with a gastroenterology, it is unlikely that if you think it is unlikely that patient will have no informations in the nervous system, so better you may not ask from the nervous system any data confidently and competently as well. This is your skill. This is your skill. The examiner usually tests this skill, which will be the pertinent information. Okay. So these are some structured history or data sheet. Usually Royal College propose such one, but for our practice, we actually following this thing almost same. So from there, one thing very important, we discussed previously about the common mistakes done by the candidates of OSCE. But one thing I like to repeat here to highlight you, the signposting, important, especially to take the private history, very vulnerable part of the patient's life. So this is signposting. Dr. Gulzar, may I ask you, what is actually signposting? Can you tell, please, Dr. Gulzar? What is signposting?
If you ask some same set of question,
For
like
example, can
sexual
you,
history,
for
like
example,
sexual
can you
history,
say, yeah, can you say how to say it? For example, your patient is Mrs. Jenny. Mrs. Jenny. So you are talking to Mrs. Jenny, you are willing to know about her private relationship and other issues. How to start with? How to say the signposting?
Mrs. Jani, I will ask some private question regarding your sexual history, which is must to know. So it will affect your uh, treatment, and anything you will told me, it will be confidential.
What do you think? Right? What do you
Yes.
think? Just
What do you think?
seeking the permission. Yes, very good. You have said, but any other colleague also can say any differently. What you are used to do this signposting. Dr. Gulzar almost corrected, correctly said. Your message should contain the aim of getting the private informations, that it will be beneficial for the patient. And very nice to hear that, to remind the patient it will be confidential. Very nice, very nice. And patient will feel free. It is called signposting. In another word, it is called the meta communication or framing of the consultation. Just to say something from the beginning that what will be my agenda immediately now. So that is very important. And they are also telling about the sensitive information you must take, you must give the sign posting. Okay. And it is actually signposting sometime maybe controversial. Somebody will say that it is not important and other, but as a general rule of consultation, it must be given. Okay. Good. So again, our history taking skill already discussed in the YouTube also. Maybe we took very recently the how to take the data. You can go through those who are newer. Even if you have actually examining colleague also, if you are deficiency in these, you can go through rapidly. It may take 2 hours time. So this is the history sheet we devised for you one by one. That we mentioned that all histories are not important, especially for the diagnosis. Okay. After the diagnosis, you will search complications, hereditary influence in the management part also. It will influence that you need to screen the family members and others, for example. So these are the major headlines, but detailed history not important for each and every patient. For example, past history, we have written here the blood transfusion, but all the disease does not need to know about the blood transfusion. For example, acute gastroenteritis, it is an food-borne disease. So blood transfusion previously not important. Please, can anyone tell me when blood transfusion history is important in which type of diagnostic disease you are thinking about? Any colleague in the past history? That patient had the
Like
history of blood transfusion. So
maybe in any case in hepatitis, jaundice.
hepatitis, jaundice, very right, very right. Any other disease? Dr. Nader Jubran, please.
Yeah, yes,
HIV?
like he
Yes,
said,
HIV,
hepatitis.
HIV.
Okay,
HIV. So you are thinking
blood-borne
about
disease.
mostly the infectious disease, right? Mostly the
Yes,
infectious disease. But very recent transfusion happened 1 week before. Patient presented with a jaundice. Could it be only infectious disease or other than infectious disease? A tricky question. For example, 1 week
maybe
before. Yes.
yes, maybe a reaction, blood. Maybe.
Yes, transfusion reactions. It is not infection. Hazards of blood transfusion. Thank you, Dr. Gulzar. Very intelligently you answered. So this is the tricks to utilize this history for the patients. But what is the mandatory part? You have to analyze the symptom in this way. And again, we highlighted many often, especially from our parts. I think some other mentors also agreed with this. When patient present with one symptom, record the symptom in your memory. Then second question will be, do you have any other problem? Do you have any other problem? Then it will give you very near to your diagnosis. Minimum, it will pull you toward the systems relevant. Patient, for example, patient presented with the fever. So again, I am asking you, your diagnosis will be pneumonia. Patient only telling the doctor, I'm having heavy fever, high fever. So if you ask the second question as, do you have any other problem? What patient could give you the answer as answer?
Yes, maybe cough.
Yes, cough. So if you,
Shortness.
yes, cough. Shortness of breath is the outcome of the disease, rather cough, productive cough. So if you don't ask about the second symptom like these, do you have any other problem? Patient may not tell you. You are busy with the fever. You are searching in the GI tract, you are searching in the urinary tract, you are searching in the skin and soft tissue, even the cardiology, many meningitis and others. So you are busy 1 minute, more than 1 minute, asking many questions about the cause of the fever. You will ask though as an open question, do you have any other problem? So let the patient say, The doctor, I have cough as well. So minimum immediately within few seconds, you will reach towards the system. And now duration of the fever, duration of the cough will tell you whether it is pneumonia or it is bronchiectasis or COPD or something else. I think Dr. Jubran, I made this thing clear to you, all of you now. Dr. Jubran?
Yes,
Doc-
May I ask one question, sir?
Yes, yes,
So,
Dr. Rizwan here, maybe.
yeah.
Please.
Sir, is it not okay if we ask the patient, could you tell me more about this? Not like similar. Do you
Yeah,
have any other problem?
yeah, actually what I observed it, if you say that, can you tell me more about this? So patient will tell you about the fever. Understand my point? So it's better to specify that you like to know other symptoms. Otherwise, patient could tell, yeah, doctor, I am having fever for the last 5 days. It is very high. I am taking paracetamol. Patient now pulling you towards the drug history. Understand? That
Yeah.
I am now taking the paracetamol. Even I took the antibiotic also by myself from the shop. Doctor, I am not feeling well. So patient already telling you about the outcome of the self-taken treatment. Understand?
Yeah, got
Usually,
it, sir.
this is the habit of our patient. So it is our suggestion, and we found it is fruitful to ask the second symptom, but patient may not tell you also. Interestingly, at that time, you will think that surrogate will be very critical. Anyway, then you will go back and ask about the fever details. Then tell, do you have burning micturition, cough, joint pain, so on. Otherwise, if you know about the cough, and the second question will be after evaluation, you thought that it would be chronic obstructive pulmonary disease, and then you could ask, do you have any other problem other than what we discussed? Patient telling, no, doctor, I don't have any other problem. Then you become satisfied. In exam situation, they will not actually tell in this way. Repeatedly, you are asking many, or for example, third time you are asking about the symptom, surrogate will not hide after your close question. Close, you understand, I think, Dr. Jubran? Specific
yes.
symptom is the close question regarding the symptom. That do you have this burning, cough, other? These are the close question. So this is very important thing. And finally, summarization. Summarizing the history is important if you are not allowed for clinical examination. But if it is a complete clinical station, after examination, better to summarize. It will save you time. Okay, doctor?
Okay. Yes.
Because if you summarize earlier, just to check yourself and went to the examination, again you have to summarize. Because without summary, you cannot tell your probable diagnosis to the patient. Okay. And then next you plan of the investigation. So summarizing, if only the history based, symptom based, or even any other problem of investigations, whatever the thing, summary is actually summary of your data, not the history. May always maybe investigation summary also you can tell if there is more investigation data are there. Okay. And in the right side, we are showing you the excreta. Excreta means, you understand, commonly the urine and stool, even the sputum vomiters. Better to ask about these red color characteristics of the excreta. Finally, flashability mainly important for the stool, but you can think yourself that order, color, amount, content, almost all of the excreta having these features. Okay. So for the baby, according to the age, 5 questions, P bind from the mother usually. And for the elderly, 4 ID. 4 ID means already mentioned, right? Routine question. When you come across a patient age more than 60 years as a routine question, because more or less they would have this thing. Minimum 1, minimum 2 will be there. Even patient presented with the dementia, he will ask about the incontinence. If patient is dementic, patient cannot communicate, maybe proxy case, wife or relative is there. So you ask from the relative also, does your father having this problem? Especially you can ask about immobility and other having problem of movement, walking. Many things will come out. Problem of the water work, okay? And then in the drug history, iatrogenicity will come out in this way. I think all of you know about how to ask. And finally, in the female patient, PPP, 3P we remember in this way: period, pill, and pregnancy. So pregnancy is most important. The lady is pregnant or not. Question is last menstrual period. It is always important question. Last menstrual period, LMP. And these are detail available, the whole discussion in a separate PDF. Those who were attached with us already, you got it or know about. So after taking the data or and the part of the summary, even after the examination also, this slide is relevant. The rule of two, how you formulate. For example, already I told you, if the patient having the fever, side by side you got the cough, productive cough. Almost you reach the diagnosis towards the respiratory system. Considering the duration and the characteristics of the sputum, you may tell it this may be a more likely case of pneumonia. So this is the rule of two. Rule of two. You can match the rule of two by one symptom and one examination. It is just actually my personal thinking. I was thinking minimum 2 features should be there. If it will be 3, this is very good. If there is a 4 in favor of your diagnosis, very right. But remember, in your OSCE exam, time is very limited. If you get up to 3 minimum, I think you don't proceed further to ask further question. Further question will be relevant if you need to manage. Understand, Dr. Gibran? For example, in the pneumonia case, you have to give the treatment for the fever. You have to give treatment for cough also, right? There is available, isn't it?
Yes.
Patient
Yes.
might have some malaise, body ache, for example. Body ache could be there. But if I think that I will give the paracetamol for the fever and I will give the paracetamol for the body ache also as a part of the management, if you skip this question, do you have body ache and other? It will not be a great mistake. It will be a time saving. Understand? This is a technique. Many often you can utilize it. But if you have enough time, your voice is very nice. You can consult very nicely. You can gather more the data. It is up to you. Exceptionally, you can ask many things. Okay. So it will be useful for you. That is the breathlessness, cardiovascular or respirology. So from breathlessness, if you think a common one for the cardiology, respirology, so if you disease from the cardiac disease, patient would have the history of chest pain. Okay. Even if the metabolic disease involving the kidney, patient will not have any feature from heart and the lungs. In general, I'm telling, there may be extended issue in the renal. Suppose in the CKD patient, acute case, there might be uremic carditis. So it is again the chest pain. But in general, for your general practice, for the exam purpose, I am talking about. Even it could be functional breathlessness. Patient will have again the positive thing, multisystemic symptom. It could be functional. So this is the hints what I understood about the rule of two. And in the data gathering, adult vaccination might be missed. In the last few years also, we were discussing about the pediatric childhood vaccination. But nowadays, it become a routine practice about the adult vaccination. So in general, in the adult patient, elderly patient must ask about the vaccination. Which vaccination very important? Minimum 2, doctor. Please, anyone? 2.
Yes, the influenza vaccine, annual influenza vaccine.
PCV.
And
Pneumococcal
pneumococcal.
also. PCV, yeah.
PCV. Sorry to say PCV. I thought that you were telling Paxil volume. So better to say pneumococcal vaccine.
Pneumococcal
Yes.
vaccine.
Pneumo vaccine, not PCV, right? In the exam also, please don't tell PCV.
Pneumococcal vaccine, yeah.
Pneumococcal vaccine. Ask about, especially if any patient having chronic illness and organ defect. Organ defect. Okay. So after the data gathering, we can switch to the focused clinical examination. So already this mark sheet is there. Again, be specific. And you are thinking that if I examine this sign, I may get finding. Remember, I repeat the word. Examination plan will be about the signs I will check, where if I examine the sign, I may get some positive finding. These are the specific signs. you will examine only these, doctor. Many often in your consultation, I observe that you are asking something not relevant with your patient. Relevant maybe for the diagnosis, relevant maybe for the comorbidity, relevant maybe for complication, whatever. But know how it is relevant. It is very, very right. Very right. For example, you are thinking patient having, without any previous history, acute case pneumonia. Okay. So when you are looking in the hand, obviously you are checking the clubbing, but you don't need to mention that I am checking your clubbing, or even you are escaping also, no problem. Clubbing is not relevant with the pneumonia, for example. You are thinking about the gastroenterology, acute gastroenteritis, infective disease due to the food and others. Okay. But you are checking something non-relevant about the diagnosis in the examination. Please, can you mention anything like this, even in the general examination part? Doctor?
No, we should pronounce this one while examining the patient, or we should do silently examination.
No, you have to say something, doctor, uttering some word, especially some examination, examiner may not understand what you are looking there. In those cases, better to say to the surrogate, I am checking your this thing. It is better way. Okay.
Okay.
Especially the very important findings you are searching for. For example, you told the patient to open the mouth. Okay. So you are checking the cyanosis. Your case is from the respiratory system, patient having the breathlessness. So can you open the mouth? Oh, I'm checking your inside any features of cyanosis. Just tell lightly, gently. It is the way, it is the standard thing. It is the standard thing, what you are looking. These are the surrogate, right? You are not getting the finding there. You don't need to say the finding to the patient like other PACES exam or other clinical exam. For this reason, like our online sessions, better to say I'm checking this thing, this thing, this thing. Okay.
Before, doctor,
Yes, yes.
before doing the examination, do we need to give the patient some general idea? I am going to examine your head or your chest or like this,
Yes. Can I
or I
examine
will
you
be
very
step by
simply?
step.
Yeah, doctor, sorry, just to say, can I examine your tummy?
Mm,
Okay.
okay.
But the examination format will be of under two headlines. One is the general examination or observation. Second is the systemic examination. Can you follow in the screen, doctor? Systemic
Yes.
examination. So in the focused general examination, all things you don't need to check. You will tell that I am looking, I am how to practice, you can remember. Can I examine you first? Patient will tell, okay, doctor. Okay, I am examining. Can I see your hand? First of all, start from the hands. So in the hand, you can say that I am checking the koilonychia, leukonychia or other. But koilonychia is especially important if you already identified the anemia there, but you didn't see the eyes now. Okay. So how can you say that I am checking the koilonychia? So you don't need to say, when you look at the nails, just to say something important will be relevant about, for example, if it is an acute case, you are checking the circulatory failure, acute circulatory failure. What will be the name of this, doctor?
Asterixis?
Capillary refill time.
Yes.
Capillary refill time. So it is the area to see capillary refill time, just press over the nail. For example, I am telling if patient is emergency acute case, no need to say the koilonychia, leukonychia, because especially the koilonychia, because you didn't find the anemia. But if your case is investigation case, patient have the low hemoglobin in the blood report, and you are allowed to examine the patient, at that time koilonychia is important. Understand, Dr. Gibran?
Yes, yes.
Actually, I cannot give you each and every example. I'm telling some example so that you can understand by yourself how to make the examinations relevant. This is the way. From there, and come to the focused examination, and you're answering when you want to expose some part of the body. Again, you have to say, can I examine your chest? Understand? For example, in
Yes.
the general examination, In the part of the general examination, with the cloth you can examine in our general practice, right? No need to say the open the chest or other abdomen, many other thing. Okay, just to maintain the courtesy, just with the patient will be of the half sleeve cloth in general there. So after doing the general examination, anemia, sinus, everything can be seen. Keep the patient seated on the chair, right? Even patient don't need to lie on the bed also for the general examination. Most of the general examination can be done by sitting position. But if you say that I have checked this thing, many thing in the lying, other, the neck, JVP, if you think, so remaining the general examination finding kept pending. Tell the patient, can you lie on the bed? You have to make the bed 45-degree angle there according to the procedure. Then go there. Then start to check remaining thing. Then come to the chest. Everything will be easy. I think the surrogate will not create any confusion there. But the courtesy of examination, permission, privacy, right? Usually if female patient is there, they will not allow to examine abdomen or the chest in general. Remember it. Abdomen, chest will be examined usually if the surrogate is the male. So there will be no problem. And the privacy is important for the female patient, right? Can I make any screen for this? You can tell the examiner, sir, I need any screen to make the patient's privacy. So you don't need, because male are there, right? Examiner, it is called the chaperone. Do you understand chaperone? Third person. Okay. So third person, usually examiners are there as a third person. If you think as a cross gender is there, so examiner may be the third person also. Even it is important. If female patient is there, if examination is needed, you can say that may I have a chaperone, or you can say a third person. It is a courtesy of the examination. Okay, then you can proceed. So we have shown you the overall pro forma of the examination planning. You will start from the hand. These are the content in the left side. Headline content, and including the bedside test. I will come to you the investigation part again. This is the bedside test. Actually, we can tell it the point of care test. Bedside is the indoor hospitalized patient point of care test in your chamber. So it is very interesting. If you utter the word, I think examiner will be very impressed. If you say that I will check your, I will like to dip the urine. I think it is mentioned here in the slide. You see in the right side, dip stick urine test, dip the urine, capillary blood, glucose, even the ECG, pulse oximetry, peak expiratory flow rate may be available on the table. If you think that, if you see that on the table it is there, you have to do it. Okay. But dip stick urine not needed. Okay. SpO2, peripheral oxygen saturation, very easy to check. Isn't it, Dr. Gibran? It is not harmful. It is not harmful, right? And surrogate will not feel disturbed. So you can check how to check the pulse oximetry. You must know it. You have done it in, even the student also can do, nurse also can do. I'm telling, for example. So you could see, you don't need to see the ECG. Okay. But in your talk, you should say your plan that I like to check. I like to make your heart tracing. Definitely you will check if you think ischemic heart disease. So you must say it. In this way, finally, the sacral edema in the neurology. Okay, doctor. Lastly, sacral edema is the last part of your examination. So you already covered the systemic part of the examination, and the later come to the leg. If you think patient is of fluid loading states are there, heart failure, liver failure, nephrotic syndrome, or any leg edema due to the drug as calcium channel blocker as antihypertensive. If it is a malnutrition case, at that time you will check the leg edema. Okay. Whenever you check the edema, your patient is lying. That means you examine the patient lying for the abdomen or other. Intelligently try to say that I like to see your back for the fluid or edema. It is very exceptional and excellent will be there. Sacral edema, because patient is lying. This is something extraordinary. I hope all of you understood. If any colleague don't understand, you can ask me please from this slide. Please, anyone. Remaining few seconds only for you if anything you like to know. No more. Thank you.
Understood. Yeah.
So we can now show you that these are the instruments. It is mostly instruments are there. ECG, you don't need to use the machine, but ECG materials, we are telling instrument in our medical teaching language or the teaching methodology language. You need to know the common ECG. We already given to you X-rays, common X-ray. And you need to know about the otoscope. What is the otoscope and utility of the otoscope? And very easily you understand that the procedure to utilize the any instrument which will be injurious to the patient, you don't need to use it in the exam. But you may need definitely a stethoscope, almost hammer plus minus. Okay, because if you press over there, the surrogate may feel pain, doctor. So you may be roughly handling, unfortunately. So if 14 candidates press over there in the tendon of the surrogate, it will not be good. Now you understood that the jacks you don't need to show. Okay, doctor. But I can remember I have done the jacks, doctor. And if I tell the surrogate, can I examine your jacks in the ankle? Surrogate didn't tell me anything, doctor. Many years before though. Okay. But thing is that I think 14 candidates are not to examine the jacks there. Intentionally, I examine the jacks, ankle jack. It may be exceptional thing. I was thinking maybe hypothyroidism, patient while having the weight gain, maybe lethargy like that for that. Anyway, so tuning fork, very easy, but not proctoscope. Likely you will understand what this. I'm just showing some material and again I like to say you that if you see some instrument on the table, on the tray beside the patient, you need to use it in general, relevant with the case. So many examination, relevant examination videos are available, especially those who are enrolled candidates we have given in the basic module. For example, the how to make and what will be the focused examination signs. Okay. And we discuss in this thing also in our YouTube about the how to make the examination focused. Okay. Especially the newer follow this. Now come to the counseling skill. The examiner mark sheet contain examination oblique counseling. Usually counseling is a part of management. Okay. You are motivating your patient for a very sophisticated investigation. It needs counseling. So directly, it is only not part of the treatment, rather in the convincing patient in course of your consultation, counseling is important. But the examiner sheet indicating that wherever examination is not needed, at those cases, counseling skill is very important. The examiner will give you the marking for the counseling, 4 grades of the marking. So in the counseling, these are the headlines again. Again, the be specific in your talk. Irrelevant talk will not be there. Okay. Very important there. And we like to tell you the basic counseling guides. Common things will be explore the problem and make patient realize to change the factors responsible for the problem. Actually, part of the management. Elaborate a specific action based on the resource available. For example, you are appearing in the South Asians. Some management or treatments are almost not available. But you are telling it. It is not good. It is not good. And allow the patient to decide. It is called mutual understanding. We should not be paternalistic or commanding. Right? This is called mutual understanding. Very important part. Very important part. That we are asking, is it okay? Is it okay? Very simple. Is it okay? Finally, reassure the patient for ongoing support. Okay, ongoing support, I like to explain you a little more. For example, that you are treating a patient of upper GI suspected of peptic ulcer disease. Your station is to convince the patient for upper GI endoscopy. Okay, so patient is not being motivated. So patient will have the fear, if I am not giving the consent, I think doctor will not treat me further. This is very important thing. So we have to assure that if you don't give consent today, if you don't agree for the test we are planning today, don't worry, we will continue the ongoing treatment for you. But I like to talk to you again because this test is very important. You are not leaving the issue, but assuring the patient that we will be continuing the treatment. Okay. And second explanation of the ongoing support is, for the same case, you are sending the patient for endoscopy to the gastroenterologist. But you are telling to the patient that I will be kept in information about you. Okay. Anything happened wrong or anything you like to know, I will be very happy to get you call. In this way, you can say. That means you will be connected with the patient. It is also ongoing support. You have to say this thing for each and every patient. It is called ongoing GP support. Not only for the counseling, even in a clinical management station also as the last part. Okay. So already I told about any procedure for the investigation. Explore, explain how much patient knows about detail about the procedures, about the investigation, even maybe a drug also, doctor. Exceptional drug, it may be part of your counseling to convince the patient for the methotrexate, convince the patient for sulfasalazine, convincing the patient for any extraordinary medication. The medication will be hazardous. Medication should be taken for months together, even for the steroid treatment for long time, rheumatologic disease. This is the steps: explore, explain, and finally explore. Last one is that how much patient understood. In our exam, we are telling to ask, is it okay? Is it okay? Like that. You can manage your time. Finally, that is the thing we discussed. Patient question: what would happen if I don't agree to have this done? About the investigation or procedure. In your motivation part, you are explaining before also that if you don't go for the investigation, I will not be able to know about your exact disease. Then treatment, I may not make a good treatment plan for you. You are motivating in this way. And last thing is the fear of postponing or withholding the ongoing treatment that I explained. So assure the patient. Okay. And any side effect of the drug, any side effect of the investigation, the procedures, if the side effect percentage, if you know about the percentage, 1%, 2%, you have to say, don't hide anything. Okay. But is a very minimum side effects, but better not to say to the patient because side effects are not that invariably will be happen. Okay. Always tell the positive thing first, then the negative thing later if patient ask. Okay. Anyway, you practice a lot, I think, about the counseling cases, stations. And summary of the counseling is, counseling always will be with your consultation. As a whole management, already I discussed, where the examination is not needed. We discussed about just previously, but in your primary counseling, this is a primary counseling station. But second thing, the whole management means, as a general case like pneumonia, you examine, you took the data as a history, you examine the patient, you make the investigation. Now come to the last part is the management. There also counseling is important. Your style of talking, convincing mode of the talking is very important. So counseling will remain throughout almost 14 stations, remember. So counseling skill is very important skill. So yeah, they are not giving the marking separately in the counseling, but think that in your marking of the management skill, counseling will remain there. Okay. So this is a counseling Google link. Those who are utilizing our learning material, already you have seen it, a detailed discussion. And now come to the investigation planning and the result evaluation. So it is not only the investigation planning. In the exam already I told you, we practice also the investigation result case. In our voice, their all colleges are not telling in this way. Practically we divided these separate category also. Already you know, we discussed about the category: acute case, chronic case, counseling case, promoting preventive case, counseling case, likely investigation case also separately there, just to make you better prepared for this skill-wise preparation of OSCE. So there also data, investigation data, I think all of you will be able to understand. These are very simple data. CBC report, liver function test, renal function test, urine analysis, thyroid function test. Okay. A little advanced if you think about the rheumatologic diseases, the SLE, rheumatoid arthritis, some infections, syphilis or others. So I think within your grip it will be. But planning is important. Planning is critical. That why will you do the investigation? You need to explain to the patient also by saving your time that I need to do this test for this reason because it will cost money. Okay, remember it. So this is the investigation. They are telling considering the patient perspective, tell in the layman language. Again, it is a part of management skill also, the common points. And the risk of doing the investigation and risk of not doing. Risk of not doing means treatment management will not be good. Again, risk means if it is the procedure, it is the risk. And this common thing also will be the management part also. I will show you the slide again. So I am not telling much detail. So regarding this thing, the investigation will be there. And each clinical station management try to do this thing. Number 1, point of care test, POCT, doctor. It will be very marvelous. In our time before, when we passed OSCE, at that time, this point of care test was not much highlighted. Even I cannot remember that we could tell in this way. But nowadays, I'm telling you very updated, very excellent modalities of investigation. Point of care test, capillary blood glucose. Almost any adult patient doctor in the chamber, you could check. It is part of the routine checking. Very simple, easy, not hazardous. So capillary blood glucose doctor, you can approach that I like to check your blood glucose by my glucometer or machine. You don't need to do it also, right? Excellent. If a patient hypertensive, if a patient that dyslipidemia, it is mandatory, right? As a part of cardiometabolic risk assessment. Very important. Any urinary case, abdominal case, you have to check the deep stick. Okay. Even the diabetic patient, not abdomen or chest. Diabetic patient may have proteinuria in the diabetic patient. Patient is hypertensive. Patient have proteinuria. Okay, you have to change the medication. If proteinuria is there, you have to switch to the ACE inhibitor. So many ways the POCT, especially blood sugar and the especially deep urine test, deep stick urine. Try to remember it, doctor, to do it. Then the laboratory test. Finally, imaging. Then invasive test somewhere important. You will not do, you will discuss about. Invasive test may be part of the counseling and others. Therapeutic trial, you don't need to do by the GP. But up to imaging, the 3, try to touch. Even technically, I thought before also, when the station is written as examination not needed. So after the getting the diagnosis, you are telling about the management. Do you understand what is missing there, doctor? After talking to the patient, you understood the diagnosis. Even it's a case simply diagnosed by the investigation, by analysis, the symptom. You diagnose the case, you know the treatment and other also. But what is missed according to the examiner checklist, doctor? Did you get the point?
Summarization.
No, doctor. Examination not
Summarization.
needed. Examination not needed written there. Summarization is a part of your analysis, summary, data gathering. You are missing actually investigation. Understand? And you jump to the management part. After getting the history and data, examination is not needed. But for your relevant diagnosis, or not only for the diagnosis, rather to identify some comorbidities, identify some complications. Understand my point, doctor? You could do some test. Minimum, you could do point of care test. Okay, Dr. Mona. Thank
Yes.
you to hear your voice. For example, you are diagnosing a patient by what I say, the blood sugar report, patient shown to you, fasting blood sugar and postprandial only, nothing there. You are explaining the report, examination not needed. Now we are going to management, right?
Yes.
So this is very good example that you need to do further investigation, is not it? Serum creatinine, hemoglobin A1C and other. So don't skip these. Okay. Don't tell that I'm giving you the metformin and the other thing you will come later. Because a holistic approach, overall management needs further evaluation for the comorbidities and others. So try to do
Yes.
up to the imaging if relevant, but laboratory test, minimum touch, or even minimum point of care test. I like to say you, any point of the investigation you must touch in your consultation. Okay. So repeating the thing, POCT is valuable initial test for the even the next investigation. Okay, you don't know, your patient don't have the symptoms of diabetes, but as a routine you are checking by the glucometer. Whenever you get high sugar, then you can plan for the next investigation. So POCT is very important. Okay, we hope that we will sit with you in general, doctor, not for examinees, about the POCT very soon. Those who will have the time, try to attend our session by the mercy of Almighty, maybe within 1 or 2 weeks. Maybe most of you today will be preparing for the OSCE. If you don't have time, be busy with the OSCE. But those who are not appearing the Colombo, keep your eyes on our group, OSCE group. You will be notified even in the AKT group also about the POCT. We are trying to prepare, already preparation is done. Anyway, so investigation planning and other, our Google Drive link also there for the details. So at the end, part of the before management, what we are thinking that our approach will be holistic. We identify the problems, not the diagnosis. Remember, as we shown in our previous days, we will show you also at the last part is after the data gathering, identification of the problems, not the diagnosis. Okay. You can remember the OSCE examiner mark sheet also. They didn't write the word diagnosis there. They're telling that it will be problem related. It will be pertinent to the problems. So problem word is very important word for you. Problem identification. For this reason, we are getting the data, we are examining the patient, we are investigating the patient. So aim of history taking, aim of examination, aim of investigation, the same. In any diagnosis of the patient, have many other things relevant, etiology and others. Try to get it as much as possible. How to do it in your shortest possible time. For example, you can diagnose the case in the history or the data. Diagnose the disease as well as exclude some differential. Few differential you can exclude from the history. But remaining exclusion you could do in the clinical examination. Okay. Risk factors and others from the examination or the history you can reach. You can reach about the complication there. But by the investigation, you can identify the complication. So if you don't reach complication in the history, don't worry. You advise the investigation for the complication also. What I like to mean, point 1 and 2. If you complete in the history, so remaining thing, complication and other, get by examining the patient, get by investigating the patient. In this way, you can make your slot of clinical approach. Everything means all 6 or especially up to the 6 point or 5 point, don't need to search in the history. Don't need to search in the examination, don't need to search in the investigation. It is just a combination. Am I clear to you, doctor? I'm telling how to manage your time. For this, I told you about rule of 2. If you get some evidence, minimum 2 evidence, I like to say 2+ evidence for diagnosis, then you will jump for the differential diagnosis, even in the history possible. Okay, likely you will proceed, doctor. Now the final part of consultation in the management, and management will be these headlines: patient perspective, layman language, risk of not getting the treatment. It is very important to explain as a part of the counseling or motivation. Okay, and the side effect of the medication is important. You need to explain if important side effects there. And common disease you must know detail. Only we discussed maybe 2 COPD asthma detail in the last few months. Is still remaining diabetes, hypertension. We will invite you in future. Keep in touch, doctor. The details of the treatment is as a clinical approach, not theoretical. So as a GP throughout the world, not only in the South Asia, hypertension, diabetes, COPD, asthma, including the tuberculosis, is important for the South Asian countries. According to the guideline, management minimum. Diagnosis you will understand, but management, doctor, I request you try to know about management. Almost everything about the management of the 5 diseases. And the management headlines, this is again the last part of the skills, consultation skills are there. But in our practical purpose, we summarize the thing in the right side box. Explain the diagnosis to the patient and you decide will you refer or not, or will you follow the patient up in your OPD, including the safety netting and how to tackle the red flags, part of the safety netting. Treatment, non-pharmacologic, pharmacologic. Non-pharmacologic is very important, doctor. Our habit is in our practice, we are prescribing the medicine. We are not talking about the non-pharmacologic aspect of the management, and it will reflect in the exam, OSCE exam. So very good thing is that you practice the thing also in your job place, non-pharmacologic treatment. It will be easier for you in the exam. Identify any ethical or the legal issue driving especially important. Opportunistic health promotion. Doctor, who can explain me opportunistic health promotion? Just few seconds. Opportunistic word here, giving an example.
Stop smoking, decrease alcohol, for example.
Opportunistic, which is not related to
with the
the
clinical
management.
presentation, yes, not relevant
Yes,
with the clinical presentation. For example, acute gastroenteritis again. Okay, acute gastroenteritis. Patient doesn't have any comorbidities, other diabetes, hypertension are not there. But what will be the important opportunistic health promotion? Smoking, right? Smoking. But smoking will not be opportunistic if patient is diagnostic of cardiometabolic disease. Likely not only smoking, if patient have the excessive, drinking of water for some reason. Patient have the false belief excessive drinking water will make the kidney clear. Okay, it is also lifestyle. It is also health promotion issue that don't drink excessive water. It will be rather hazardous. Now kidney is okay, but in future. So in this way, you can decide about the opportunistic. Very good, doctor. Thank you for your interaction. Management skill and the referral knowledge also we'll discuss. We already discussed, doctor. I believe most of you attended our discussion before. So these are the headlines, doctor, I'm discussing today, and this is your final sheet. Final sheet of your data gathering. So already you practice a lot with us before and try to remember this thing, but you can make it up and down, doctor. That whenever you think that patient, I need to take the patient past history in the your data gathering, you can take the past medical history. Drug history is important, you take the drug history. You can make a reshuffle. The child case, then it is mandatory. If not, child not needed, like this. You are not giving any medicine today, for example. It is a purely counseling station. If you skip the drug allergy, it will not be a great mistake for today. Okay. Likewise, you can make a customized pattern for you. But we were thinking, and still we are thinking, this checklist is very useful. Almost all of the things to be covered in your consultation. So final message for you, doctor. for OSCE aspirant immediately, our tips is to save your time. It is very important. Read the system-wise case, cardiovascular, and why I am telling, I observed in the last few years also, our colleagues are very serious about, even in our course we designed before also system-wise. How many systems are there? For example, 14, 15, 16. But nobody will tell you that this case is coming from the system. Patient present with the symptoms, patient present with the features characterized by the acuteness of the disease, chronicity of the disease, or the investigation report and others. So try to practice mainly category wise, acute case, chronic case likewise, but gather the knowledge about the disease from system. Okay. If you have a lot of time, okay, you can finish system wise. It will take 1 years, doctor. 1 years. There is no boundary of the system case, but category is limited. Around 7 or 8 categories are there. If you do category wise, your practice will be better, your examination will be smooth. This is our experienced suggestion, doctor, for you. Okay. And many things we discuss in our YouTube, doctor, for you and near about. And it is the OSCE WhatsApp group. I don't know, maybe you are the member like before. Any interestingly new colleague there for you, doctor? Get the link. You just click and enter with us. Thank you very much for your patient hearing.